All right, that was the time we found glitter on the plunger. Neurodynamics. Okay, so what I want to do is again is briefly go over the. I want to briefly go over just the concepts and whatnot. Okay, maybe a couple mechanical things that I'm pretty sure I covered in lecture, but we'll reiterate it, and then we'll go over the sequencing, the hand position, the sequencing, and the form, and then we'll practice those. Okay, and so what I'll actually do is we'll instead of just making one long video like we did last week, we'll break it up into pieces so it'll be easier to upload when we get there. Okay, and so we'll actually have this portion, and then we'll have the ulnar nerve test. Well, excuse me, median nerve 1, ulnar nerve. They'll all be separate videos. All right, cool. So remember, the big thing here when we're thinking about neurodynamics is we're basically assessing how a nerve slides, how does it tolerate pressure, and then any type of physiology issue that's going with the nerve, whether that's interruption of intraneural blood flow, some mechanosensitivity, excuse me, or inflammation around the nervous tissue. In particular, like I mentioned in a lecture, if we have, we'll just use lumbar disc herniation here, and the nucleus is exposed to the like inflammatory, like to create it's exposed outside the annulus, you will have an inflammatory response to that. Okay, we're not gonna talk about the inflammatory markers yet. We'll wait till next week or the following week to talk about that. But that could really irritate a nerve. Okay, and it doesn't matter what you do mechanically, like extension or flexion, adjusting. There's physical inflammation on the nerve root. So you doing anything mechanical to that is not going to change that. All right. There may be some things nutritionally that we could do to try and make a change there, but mechanically we're not going to make any big gains there. Okay. The thing we would do mechanically though is try and reduce whatever the injury mechanism was. We'll try and reduce the potential of that happening again. So if that was like if they hurt their back, blew their back out when they picked up a paper clip off the ground, it's probably poor hip hinging, right? So we'll give them stuff to spare the spine so it doesn't happen again. Again, we're playing first aid to that nerve root in that scenario. So when we go through neurodynamics, a three-part system here. We have the nerve, we have the interface, that's where the kind of nerve interacts with portions of the body. Bone in the foramen, right? That's a nerve interface. And then all the tissues that the nerves innervate. We didn't go over the femoral nerve tension test, did we? No. I think maybe one person here can probably do that. No, you can't. So remember, we're going to operate in our standard neurodynamic test anywhere from 8 to 15%. Okay, and you can put somebody in a full slumps test, and we're stretching it about 15%. We can also put the next person in a full slumps test. We're only stretching about 8%. Right? Depends on that person's mobility as well. Some people are going to have more lumbar flexion. They're going to have more thoracic flexion. They're going to have more cervical flexion. Some people are just going to have a really stiff spine, and so we're not going to get as much gross flexion, global flexion as we normally would. Okay, usually some people just have general stiffness through like the posterior chain, and so we won't get as much range of motion on a straight leg raise or a slumps test. We're gonna We'll go into a little bit more the specific longitudinal and the transverse sliding when we get into the most of the treatment options that we're going to go over. Probably won't go over today. I want to spend more time on the tests themselves, so you guys get the groove of those, so you can get build the skill of feeling. Okay. But the treatment options are going to be in place when we start getting into disorder management sections. Okay, so like the lumbar static openers and sliders, we'll go over in the lumbar section. Okay, The wrist static opener for carpal tunnel, we'll go over that for the wrist section. Okay, same with cervical spine too. Okay, sliding progressions and nerve root and static openers and whatnot. Again, the reason why we can't talk about exercise or active care if they're really uber irritated. And the reason why I emphasize the neurodynamics section here is because it's often way overlooked. And I teach it this way is because I learned it from somebody who literally does this. This is all they do in practice is neurodynamics. So he gets referrals and he does for people for neurodynamic assessment and treatment, and he does research on it every day, right? And so there's a reason why we're going over this. It's not just to give you guys and hope that you start doing neurodynamics. Can they withstand compression? But the gold here is in the structural differentiation. So remember that the structural differentiation is what we're going to use to say whether or not it's nerve tissue or if it's a local tissue. All right. So if they have hamstring discomfort or hamstring tightness, we'll do a neurodynamic assessment to see whether or not that's actual tissue or or nervous system. Okay. Now, what's going to happen is you're going to have people come into your office and they're going to be sitting down, just like most of you are, and they're going to say, my hamstring's tight. And you'll ask them, so you sitting down right now, your hamstring's tight? Yes. So it feels tight. They're going to say yes. They're sitting like this. Is the hamstring on stretch? Not particularly, right? Because we're in knee flexion. This would require hip flexion and knee extension would require the hamstring to be on stretch. So that gives you, already tells you that there's some neurogenic sensations going on in the posterior aspect of the thigh. But when we do that, when we find tension or we find some type of reproduction of symptoms, we want to skip a joint. If we can skip more than one, excellent. Okay. The further away we can wiggle the nerve, the better. Sequencing is important, okay, a slight change in hand contact is uber important when we're talking about assessment of just standard testing. So in my group, my group in the Tri-8s, we were rehashing some of the neurodynamic stuff that we went over last week, and we were doing median nerve, and I purposely had the fingers wrapped around my hand like this, these two fingers here, because remember the median nerve spans over these three guys here. I purposely had just dip flexion, okay? And I did standard neurodynamic test and I went all the way out with no reproduction of symptoms or anything. I said, okay, now I looked at one of my interns and said, okay, now I just want you to extend both dips. Don't extend the fingers, just extend the dips to be neutral with the rest of the fingers. And he did that, and the face lit up, the patient, and you could feel the arm start wanting to creep back in, just from this. Okay, so technique is important. When in doubt, it's okay for you to peel back and start over, okay? Some of your hands are not going to be big enough to span over the second and third digit. So that is another option, or excuse me, that's another scenario when we can use median nerve 2 test, because it's easier to span over the hand. Okay, what's the other scenario we might use median nerve 2? History of shoulder dislocation, so shoulder instability, right? Well, if they've had it surgically repaired, don't even play with it, just do 2. Okay, don't even go there. Obviously, we've already gone through all this stuff here. Just examples of suspected conditions that we'll apply neurodynamic tests to. Remember, what you say to the patient before you do the test is pretty important. Okay, you got to let the patient know that you know that there may be something going on, some symptoms they feel in the arm. Okay, but it's important to let them know that if they feel anything at all, have them tell you when it happens immediately, and then verbally describe it and where. Okay, and ask them, try and be as swift as possible with your response, because what you don't want to do is we're not going to hold them in attention, or so they have a lot of tension. We're not going to hold them in attention for very long. It's going to be really quick. We got to get into it, verbally tell, then you verbally give them the cue to where you want them to move from. If you want them to do contralateral, lateral flexion to increase tension there, and then get out of it. All right, and then your very next question out of your mouth is, the symptoms that you felt, did that reproduce your thing you came in for? Or did that reproduce your symptoms? And if the answer is yes, then we have a positive neurodynamic test that is abnormal. Remember, you can have a positive neurodynamic